Thank you so much, Ricardo. So let's get our language right. Barriers for LGBT and sex workers, including adolescent girls and young women, prisoners, mobile populations, migrant workers, to access comprehensive SRHR services. That's what we are really talking about. I have also an esteemed panel to introduce today as part of this topic. They are Professor Finn Regan from the Human Science Research Council, Sam Machikuri, Gay and Lesbian Alliance of Zimbabwe, Victoria Kamule. Victoria is representing Namibia from an organization called Tonata, a network of people living with HIV. And then also Kosi Ume, Y+, Global Nigeria. And Doreen Moracha from I Am Beautiful Story, Kenya. So quite an esteemed panel. I would like to start off with Professor Finn Regan. What is the role of the global pro-family counter movement to SRHR in the region?
Great, thank you so much. And good afternoon, colleagues, and thank you for the invitation to be here today. It's a pleasure. The Human Sciences Research Council, the HSRC in South Africa, is one of our statutory research councils here. And our mandate is to develop the evidence base, the research base, in service to reducing poverty and inequality, both nationally and across the region. One of our priority areas at the HSRC is sexual and reproductive health and rights, both nationally and regionally. And we have a range of projects being rolled out across Eastern and Southern Africa in and around the broad area of sexual and reproductive health and rights. One of these projects is the Schools Out project, which is across 10 countries in Eastern Southern Africa, a partnership between researchers and 16 civil society organizations. So very briefly, I'm going to touch on one of the barriers to SRHR supports and services that has emerged through our work on Schools Out, and a rather surprising one, not one that we had anticipated. There's a growing evidence base, a research base around this particular barrier, this particular challenge nationally and globally, but still extremely limited research on this. And I'm referring to what's called the Global Pro-Family Movement, our anti-gender movement, which is a transnational coalition of anti-progressive activists and organizations working to counter sex and gender-based rights and SRHR more broadly. As far as we are aware, it's a global movement, including in Eastern Europe, Southern America, across the continent here in Southeast Asia. And from the limited but growing research we have regionally and globally, the arguments and ideology of this movement are that SRHR, gender equality, feminism, children's rights, and sexual and gender minority rights more broadly are a fundamental attack on the idea of the natural family, that they're seen as an attack on religious freedom, attack on traditional values and on children themselves, and are in effect SRHR, gender equality and LGBTI rights, including children's rights, are a form of population control. They're a neo-colonial agenda and a sexualization and exploitation of children. In effect, this agenda seems to be one of discrediting and blocking SRHR, including comprehensive sexuality education across Eastern and Southern Africa, as a way to, I suppose, promulgate and maintain male dominance and systems based on exploitation of women and children. It seems to be a rolling back, an attempt to roll back the global human rights paradigm of recent decades and the democratic values underpinning that. As far as we can tell, this movement originates in the States, going back a number of decades, and that one of the key strategies of this global counter movement is that of influencing government. And we see that playing out in Hungary, in Eastern Europe, in Kenya, here in the African continent and elsewhere. We have examples that we're currently further developing the evidence base around. We're doing research at the moment in the region around examples such as the Stop Comprehensive Sexuality Education campaign. The Stop CSE campaign is being rolled out in Tanzania, Uganda, Zambia, Nigeria, and here in South Africa. And why is that a research interest for us? In many ways, we see that as we move to December and the expiration of the Eastern and Southern Africa commitment around comprehensive sexuality education in schools across the region, we know that our development partners, the United Nations bodies, governments across the region, civil society organizations themselves and other stakeholders have generally been unprepared for the effectiveness of the engagements of this counter movement in its attempt to roll back CSC and SRHR, including linking young people, it seems, in schools to the SRH supports and services that we need. So in short and very briefly, this is one of the surprising barriers or possible challenges that has emerged in the region, according to our research, on how, in terms of blocking access of young people in schools to SRH supports and services, to be an approach that further exacerbates stigma and discrimination. And we're hoping to develop further the evidence base around this counter movement and the effects and the successes of this movement, including in Namibia recently, in terms of supporting an appropriate and robust policies response, and of course, supporting civil society in its work. Thank you.
Thank you, Finn. I'm sure we'll come back to this discussion also later in the Q&A. We still have a long line up to go. Samuel, what are the experiences of LGBT community in dealing with stigma and discrimination in Zimbabwe?
Good afternoon, everyone. Thanks for having me. Based on some of the presentations that we had since we started, a lot of the issues were brought up. But I think in Zimbabwe, given the history of homophobia that has permeated all structures of society, including even the health sector, you find that in many ways, communities are denied services where healthcare workers have not been trained, which is still a huge problem, given that we only have a few services that have emerged in the last 3 years. If you look at the epidemic, when it started, it was seen as a gay disease. And in Zimbabwe, you find that LGBTI organizations like ours really started to respond to communities. You look at it 35 years later, you find it's only in the last 3 years when national programs started emerging to actually respond to HIV services, for instance, for men who have sex with men, for transgender persons. But when you look at the broader scope of LGBTI community members, the services are quite limited. So you find that when people then visit facilities where they have not had any trainings at all, the issue around Bible comes in. This is an African, this is an Christian, while of course in the process of actually getting a diagnosis and getting a service. We've also noted that when people think about who actually reinforces stigma and discrimination when it comes to access to health services, we've realized that it starts at the entrance where services are provided. The security at the gate, when they see a trans man or trans woman coming through the gate, the stigma is expressed overtly and sometimes openly. You find that even at that administration level, when the person is getting a card and it's being registered, there are questions: what name did you give? Are you a man or woman? And then when they finally get to the healthcare worker who's supposed to save them, you find also that healthcare workers do not have much knowledge on dealing with key populations, specifically men who have sex with men and women who have sex with women or transgender persons. They don't have much skills and the competence in history taking, which half the time you find that healthcare workers then are interested in getting the juicy bits. How do you have sex? Do you have a family? Do you have other gay people? Then actually addressing the need of the persons that they've presented. You also find that because of the homophobic rhetoric that is within our political realm and social spheres, people actually present with late diagnosis of HIV. They are already sick, they are already ill, they are desperate. And when they present themselves, you find that there's still that language that perhaps you deserve the illness because what you're doing has been deemed un-African, it's evil, it's satanic, or within the political realm, you know, whatever the former head of state, for instance, Robert Mugabe would say, becomes the law. If we can be called pigs and dogs, it means you are treated by healthcare as a way that it becomes inhuman, that dignity that we speak about, the human rights approach that we all subscribe to, even within our constitution, is neglected. And you find that the breach of confidentiality, even for healthcare workers that have been trained, still happens because I think people miss the power of language. We always say language is not innocent. It can be through the body language. It could be some of the words that we throw around, not realizing that you're actually reinforcing stigma and discrimination. And you also then realize that a lot of community members, when they try and then access services, there's also that geographical push that happens. I don't want to get services within my locality. I'll rather go to the next health facility. But of course, it comes with cost in terms of travel, in terms of access. You also realize that some, you know, in a study that was actually done by Mutanga and at in about 2019, you realize that people actually prefer to go to private hospitals because they feel they are listened to, they are given the best healthcare. Because in our public health facilities, it's already overwhelmed system that is also trying to push in all the numbers, but when the services that are then given to our communities, you find that stigmatization happens. You realize that the people then tended to or would like to opt for other medical options, which is moving to the traditional concoctions that are availed on the street. And you find that the deprofessionalization then comes in. But of course, we've also realized that in the last couple of years, we've also actually been implementing key population services. There's also what we call courteous stigma, which is also assigned to those that are actually trying to save the communities. We've had healthcare workers that are saying, I now have precarious trauma because of the issues that overwhelmed me, because other healthcare workers within that facility are not willing to save key populations. In their absence, no one really wants to address key populations. And I think that reinforces stigma in the community in that you are not wanted, you are not valued, you are not a person, and we are only doing a favor to you when you provide services. And I think those are things that reinforce stigma currently in the Zimbabwean context.
Thank you so much for sharing, Samuel. And one can see already that there are commonalities in terms of the speakers' issues that they're raising around stigma and discrimination. Moving on swiftly to Victoria. Vicky, can you share some light in terms of issues pertaining to people living with HIV, as well as in your view, is there a balance in terms of priority funding for psychosocial support as opposed to prevention and treatment? You're muted, Victoria. Can you unmute yourself?
Sorry for that. Thank you very much, Salen, for that question, and thank you, everyone. As it said, my name is Victoria, and I'm representing the network of support group in Namibia. The barrier that we have in terms of there is slightly an imbalance, I should say, when it comes to priority in terms of the funding. We are now looking at the 390s, and it is well categorized, and priority is given to funding towards these 390s. But then in my own view, and as a person advocating for people living with HIV, I think the issue that is not being really taken care of is the psychosocial needs of people living with HIV. So when you go, for instance, to the health facilities and you are tested to be HIV positive, all you get is just that counseling that is just a tick box counseling. but then structures that are in the community that is supposed to continue to support this person in terms of making sure that this person come in terms of their positivity, and they are supported to accept and understand the fact that they are now living with HIV. I think that the part is played. We played a role in support groups, but then that is just self-supported in terms of the community coming together with insufficient, or rather not support at all. Not even a lot of organization would concentrate on giving education or additional. We have a system of social workers in this country, but then I'm not sure how that social workers are so well linked into the community structures for them to be able to continue to render that support that is lacking in my own opinion. So you rather go there to support groups that are trying their own level best to support one another with a lot of limitation, and you find people are coming together. At some point they try to form a support group, and because of lack of additional support and information that they need, you find support groups are formed today and die tomorrow, and then you try to go there with all the limitation to kind of motivate them, but then a lot of these structures are not really paid attention to. And I feel that the fourth 90, I like to call it the fourth 90, the psychosocial need is totally, for me, in my own opinion, it's linked to the mental health issue. And the mental health issue in Namibia remains a challenge when it comes for it to be incorporated in the HIV component. I think that's what I have to say around psychosocial support.
Thank you so much, Vicky. Is affectionately known in Namibia as Meme Vicky. So thank you so much, Meme Vicky. Moving on to Kosi. As a young person and as a person that works so closely in the community, what is really the harm that intentionally and unintentionally strategies, programs are doing in our communities when it comes to young people and young vulnerable people, in terms of what you are seeing daily, what you are experiencing daily, stats aside?
Good afternoon, everyone. Thank you for this opportunity. And for young people, we face we have some challenges, and coming from the aspect of someone working in the community, we have stigma and discrimination, which we face both at healthcare facilities and amongst our peers too. But amongst the peers, then we have the self-stigma, which is actually a serious issue amongst us. Then there's poverty, and there's lack of adequate information. And for these fews now, when it comes to our young adolescent girls, we found out that they do well, they do well on treatment at the early stages of 19, 18, but once they get to 22, 21, it's more like everything is just, they lose hope, because at that point they're getting into relationships, and they start battling with disclosure, and how even those that have been disclosed, more like they are into emotional blackmail with the partner, and all this pressure and stress that's making them lose faith in medication or ART and start going wild. Then for our key population in Nigeria, we have strict laws. And if in the northern part of Nigeria, there's a death penalty. In the southern part, there's imprisonment. And it's actually very is making things very hard because if young people, young key pops find it even if harder to even trust because as much as they want to access services, they want to access care, and when they get to the health facility, the health facility has a stigma against or discriminates them because the society labels them as I'm looking for the right word, but it labels them as threat. They insult them, so when someone comes to pick get services and you're judging that person, so it affects them, it affects the services they want to. So most of them prefer to find a way to get their medications maybe in a pharmacy, but luckily for us, some organizations have the OSS for them in different places of the city, which they can go and get some treatment, get their services and everything. But for lack of information, just last month we found out that a lot of young people don't know. I'm talking about the general population now, not just HIV or just a normal young person, doesn't have the adequate information about HIV or the UE port to you. We found out that when we do post on social media, those that like our posts, those that comment on the post are still those people that follow us on the NGO world, the all humanitarian. But these young people here don't have those information. And if we can get them, if we can educate them on HIV, which we are trying to do, we are trying our little best, little as we can do to educate them on all those aspects. And if we can educate them there, at least we are solving some part of stigma and discrimination, and it's getting reduced there because as much as we are hammering on our own people that are living with HIV, we also need to bring along these young people that are not living with HIV. And I can suggest not just social media, we can move using entertainment, the movies. If we can have all these messages in just buried into these movies and people are watching it and we're having this social education, people are watching and learning. It doesn't really have to be all HIV, just be in the movie and people can relate and say, oh, this is, and it could help. And all this can play side by side and it can help us to suppress this stigma and discrimination as it is. But for self-stigma is kind of one of the hardest and one of the strong part because a lot of young people are still in denial. Even after years of being on treatment, they are still in denial. Uh, yeah, I have a friend and she's still in denial and we're trying our best, but she keeps on going from first to second. Now she's on third. And Nigeria, we don't per se have a third line. We try different formulas to know if you can survive. And this has caused a lot of young ones to, in this some facilities, to lose hope. And
Absolutely.
yeah, so we are now doing more of okay. I have to take a step back and say, okay, let's have a review. Let's go more into personality. Let's go inside. Let's try to pick them one after the other. What is he thinking? What are you thinking? So we have a social WhatsApp group, and people come into the WhatsApp group. We talk about HIV. We talk about ARTs, and in after talking about it, you try okay. Let's see how people are going to get there. People are getting whether people get information, but then we're getting there. Then COVID-19 happened, and there's been a lot of setback because of my closeness to the community. A lot of young people actually came up because I kept on asking how are you guys doing, and few have opened up to me and told me that during the COVID-19 they had to do some transactional sex, and I can imagine how much more because if I can get a number from just a little one community, just imagine how much more I can get in the whole Nigeria or in Africa and beyond. So all those things are questions. So it kind of have ask questions that so in few months, we should be, if we do testing, we should be seeing, either we're seeing positive results or we're seeing pregnancy, because pregnancy too is another challenge too, because we have some young girls getting pregnant because they knowledge of etc. And that's another challenge, and I think that's another place that we are going to look into. And if you can have information, adequate one, everywhere, anyhow, in every language, no matter the situation and how we're passing the method, the mediums are passing these messages, I think it will go a long way. It will go a long way to solving a lot of our stigma and discrimination issues.
Thank you so much. Clearly, it's very inspiring, the youth-led interventions and strategies that you're already talking about, that works and that is important. And we are listening, and we are thinking that it should not only be about what are the issues, but how can we move towards best practices and solutions, and what are really the issues that have worked in different countries. And thank you for highlighting that. Doreen is our next speaker. Doreen is from I Am Beautiful Story. And the question that I have for you, Doreen, is how can we use human-centered design to access barriers for, as we say, LGBT and sex work populations, youth, adolescent girls, and young women populations to access comprehensive SRHR services? Doreen, over to you.
So thank you so much, Salen, and thank you everyone for being here this afternoon. My name is Doreen from Nairobi, Kenya. I am the founder of I Am a Beautiful Story, which is a HIV and AIDS anti-stigma campaign, if I can call it that, because I purpose to use my story as a person living with HIV to impact on other people living with HIV like me, to see that if I have lived with HIV my whole life, they can do so too and live many, many more years. So how we can use human-centered design in addressing the barriers that are affecting the ease of services for sexual reproductive health and rights among key populations, which are the LGBTQI, the adolescent girls and young women, the people who are injecting drugs, is bring them to the table. Because most of the time, you find that we have these nice policies that we go for these high level meetings, we go for different forums, and we sit and talk and come up with very nice strategies. But unfortunately, most of the time you find that most of the people who we are talking about are not actively involved and they are not at the table. So bring them to the table and ask them, what do you think works for you? How can you easily access services in your country? Because in Africa, most African country setups, as we saw earlier on during Ricardo's presentation, there is a lot of criminalization for key population people, a lot of criminalization. And you find that at some point there is a disconnect, especially when it comes to the law, whereby like in my country, Kenya, there is the penal code says there is health is a right for everybody else. And then the constitution goes ahead and criminalizes sex work and LGBTQIA community. So then when a healthcare worker is handling this patient, maybe it is a sex worker who was raped, they're like, so do I handle them? Do I treat them? Or do I not treat them? Because the law is against sex work totally in Kenya. And then there is the penal code that gives this person rights for health. So how do you deal with that? Bring both parties to the table, both the healthcare workers and the people who are actually affected directly by all these sort of what is it called, disconnect in the law, because it's more like an overlapping thing. Bring both of them. let them know that, let the nurses or the healthcare workers know that there is nothing wrong with treating this person, because before they're a sex worker, before they're a man having sex with other men, before they're an adolescent young girl who got exposed somehow to HIV, they are human. And it does not matter what the law says. This is a human being. So treat them first as a human being, and then you will figure out about the law later on. And also bring on board the policymakers, because these are the same people who are out there making the laws. Most of the time, in my country, there is, what can I call it? We call it a gray area, because it's not really mentioned that we don't allow this. But then there was the issue of abortion, safe abortion. It brought about a very heated campaign last year when one of the female parliament representatives wanted it to be very legalized, because currently we have a teenage pregnancy crisis in this country. And since Corona started, it actually spiked. And now we are, after COVID, we might even be looking at a more double number of young women living with HIV and a higher teenage pregnancy crisis on our hands. So when this came about, the whole bill included comprehensive sexual education. It included legalizing safe abortions. It included family planning methods for teenagers, adolescent girls, and young women. But it was thrown out because people were saying, you're trying to teach our children about sex. But have we gone to the children themselves and asked, what do you know about sex? We have not normalized talking to sex about our children, and that is making them explore. That is making them go out there and want to do things on their own because, hey, they want to experiment. And we tend to forget that we are currently in a century where children are not what we used to be when we were growing up. When we were growing up, we had no exposure, literally. And parents think that by telling their girls and boys that stay away from girls and stay away from boys, then that is sex education. That is not sex education. So we have left our adolescents behind because we have not brought them to the table. We have not used them to tell us, what do you want? What do you want us to teach you in these life skill lessons in school? Because we have a life skills lesson in school, both primary and secondary school. But those are lessons that teachers use to cover up for the lessons they missed at some point. So there is no life skills being taught. So the teachers are just forgetting about that, and they're like, today we are going to refer to maths, that is something we taught. And then we're leaving these kids behind. I once went to this school and I was giving a talk about HIV and my story and all that. And so I asked these kids, can you please ask me any question? So everybody was quiet. Then I told them, ask me a question anonymously. So they wrote the questions on the paper. Every other kid wanted to know how to have sex without getting pregnant, how to have sex without getting infected with HIV, how to have sex and just literally get away with the consequences of sex, which means we have left our children behind. We have left our LGBTQI behind because we feel they're not human enough. Society did not put us in, our societal norms did not train us that one day we are going to have women marrying each other, that one day we are going to have transgender women. We believe that you're either born a woman or a man. So it becomes very hard to connect to these people. And also the society at large, because as much as we want to bring everybody on board, we want to bring the sexual workers and say sex work is work. We want to bring the adolescent girls and young women and tell them, this is what you have, this is what you use, this is how you negotiate for safe sex. We want to bring in everybody else on the table, even the healthcare workers. We also need to bring in society, because society will also still discriminate. And when you're a key population person and you're living with HIV, you face double stigma. So it is stigma against your HIV status and stigma against the fact that you refuse to conform to societal norms. So can we please bring everybody to the table and let them speak and let us put their thoughts into actions? Thank you so much.
Thank you, Doreen. Inspiring words, passionate statements. Thank you so much. We clearly know where are the gaps, where are the challenges, both at regional, national, service-based, and at community level. And it sounds so simple, leave nobody behind. Think about the legal frameworks. Language is not innocent. Let us think about the realities of comprehensive sexuality education. Let us think about specific communities, whether it's adolescent girls or young women, young people, boys and men, LGBT communities, sex worker communities, and how we can all work together towards a comprehensive and common goal. I want to thank all the panelists for such passionate remarks, thought-provoking statements and contributions. And also there has been tons and tons of questions streaming in, from thanking the panelists for bringing in the fourth 90, thinking about the bringing in of mental health, not only within COVID, but also within our comprehensive interventions. People do agree with access barriers are structural issues, and how thoughts are also about what do you think can be done to encourage governments in Africa to really and fully embrace the importance of eliminating these kind of barriers. I know that, Ricardo, I did not ask you a question. Do you want to mention a strategy that you know that have worked, and to leave us with that sense of it's not all in vain. It's not all in vain in terms of what we want to do, and to keep the strategies going.
Celine, you've given a really good, inspiring word to finish. It's not in vain. So I think we should take your word there. I maybe as my closing comment, I'll stay on message about a structural position on this. And I maybe want to make a response to a comment that Anna-Marie said in the previous session. Celine, you've just made the comment, we know it's not all that easy. I want to suggest it's much easier than we pretend it is. So Anna-Marie talked about Namibia. We've started a process. We've had a conversation. Namibia endorsed its constitution in 1990. It has been 30 years since that country committed to protect the rights of everyone, equal under the law, the rights to dignity and non-discrimination. 30 years is not a short time to get the process started. And so I think my comment is the same to Zimbabwe and Kenya and Nigeria and South Africa. These solutions are much simpler, perhaps, than we pretend they are, and that we kill ourselves as civil society to effect. We have to hold our governments to account for the promises that they have undertaken. We have to not accept that this will take a while. We're in process when we have constitutions that guarantee rights, when we've signed international instruments like Anna-Marie talked about, the ICESCR, that guarantee certain rights and freedoms, that guarantee dignity. Criminalization is decidedly anti-dignity and discriminatory. And I don't know that it's as difficult as we keep imagining it to be. People need to do what they say they will do, and we are part of those people.
Thank you so much. It's always time catch up when you're having fun. I'd like to thank the panelists and declare the end of the session.